Hello, everyone, and welcome to the next installment in our series, Dr. Gilbert Hosts. My name is Dr. Rebecca Gilbert, and I am the Chief Scientific Officer at American Parkinson Disease Association. Thank you so much for joining us today. We will be having a conversation with Dr. Kathleen Poston, an expert on cognition and PD. Dr. Poston will give us a short introduction about the topic, and then we'll be answering your questions in a Q&A session. I'd like to thank our sponsors, Acorda Therapeutics and Genentech, for generously supporting this programming. American Parkinson Disease Association, or APDA for short, is the largest grassroots network dedicating to fighting Parkinson's disease and works tirelessly to assist the more than 1 million people with Parkinson's disease in the United States live life to the fullest. Please visit our website at apdaparkinson.org to explore all that we have to offer. You can contact APDA also through our toll-free helpline, which is 1-800-223-2732, as well as via our social media outlets. My guest today is Dr. Kathleen Poston. Dr. Poston is Associate Professor of Neurology, Neurological Sciences, and Neurosurgery at Stanford University. She received her bachelor's in bioengineering at University of Pennsylvania, her master's in biomedical engineering, and her MD at Vanderbilt University. She completed her neurology residency training at UCSF, completed a fellowship in movement disorders at Columbia University, and then did postdoctoral research training in functional neuroimaging at the Feinstein Institute. Dr. Poston's research and clinical emphasis is to understand the motor and non-motor impairments, including cognitive difficulties and dementia, that develop in people with Parkinson's disease. She holds joint appointments in movement disorders and memory disorders, and is a founding member of the Stanford Alzheimer's Disease Research Center. She's also co-director for the Pacific Udall Center, an NIH-funded Parkinson's Disease Research Center of Excellence. I am very excited to be talking with Dr. Poston today. Dr. Poston, welcome, and thank you so much for joining us.
Thank you so much, Dr. Gilbert, and thank you to the APDA for inviting me to talk about this incredibly important topic of cognitive impairment and dementia in Parkinson's disease. So I'm just going to go through a couple of slides to orient all of our listeners and viewers on what this avenue of Parkinson's disease is and why it's so important. So just like the motor symptoms of Parkinson's disease, where some people get tremor and some people get slowness and some people get stiffness, and some people have walking problems, cognition involves a lot of different subdomains as well. It's not just memory. That's one of the reasons why we talk about cognition, not just memory. Memory is just one aspect. And in fact, in Parkinson's disease, the two most common types of cognitive problems are executive function and visual spatial function. So let me just briefly explain what those are to put that in context, because that'll really help orient the rest of the slides. So executive dysfunction is basically how you operate around your day-to-day activities, multitasking, organizing, figuring out what you need to do in order to get things done, what kind of things need done in the morning in order to get out the door and get to that doctor's appointment, or to get the kids out the door to go to school and things like that. Another example of executive function is the ability to incorporate new information into your decision making, where you're planning a weekend away and then all of a sudden you get news of a severe weather alert that there might be a lot of snow coming in, and maybe that road trip to go see grandma is not the best idea, and you need to reorganize that and plan it for another weekend. That's another executive function, incorporating that new information and changing what you're doing accordingly. Visual spatial reasoning, or visual spatial function, is how you interpret the world around you and incorporate the visual information into your decisions. So this isn't just visual functioning, it's visual decision making. And so things like when you're parking a car, how do you make sure that car gets into the parking spot correctly without nicking the car on one side and the curb on the other side? How do you walk into a room and see a chair you want to sit into and take the appropriate number of steps, turn at the right time, and sit at the right time? That's all decision making based on your visual spatial environment. And those two aspects, executive function and visual spatial, are the two that are hardest hit in Parkinson's disease. Now, the other ones can be involved: attention and working memory. Attention is how well you can focus on what you're doing and ignore the things that aren't important, like ignoring your email right now while you're listening to me talk. And working memory is the ability to keep information in your head just long enough so that you can use it and then it's gone. Like the information of hearing somebody's phone number or their web address and typing it into your phone, and then all of a sudden you never think about that phone number again. Memory is memory, the ability to remember the conversation that you had yesterday, the breakfast that you had today, to remember that you have a doctor's appointment tomorrow that was scheduled 3 months ago without looking at any reminders. And then language, which is the least commonly affected in Parkinson's disease, is simply the ability to name objects. So do you know the name of things when you see them? And so all of these can be affected, but the top two are the most affected. So what do we do as a clinician when we think about cognitive function? How do we test for these things? We're all very familiar with the motor test, right? The finger tapping, the hand open, close, walking up and down the hallway. These are how we test the motor symptoms of Parkinson's disease. Well, we as physicians also think about testing the cognitive symptoms, but it's a little more difficult. In the clinic, we use screening tests, and this is the most commonly used screening test. It's called the Montreal Cognitive Assessment, or MoCA. It's gotten a little bit of publicity over the past couple of years, but it's a very good cognitive screening test. It's not perfect. You can do poorly on the MoCA because you got a bad night's sleep last night and not because your cognitive function is poor, or because you got really anxious when you were doing the test and you kind of didn't pay attention when the doctor was giving you the instructions. So just because someone does poorly on the MoCA does not give them an automatic diagnosis of cognitive impairment, but it's a good screener. It's a good way for doctors to get a sense of what's going on. To get formal cognitive diagnosis requires a comprehensive neuropsychological evaluation, which is typically done, takes about anywhere from an hour to 4 hours, depending on how extensive it is. And it really goes into details of all of these different functions: the executive function, the visual spatial function, memory, attention, and language. And so between these two things, we can screen for cognitive functions in clinic, and then we can also get more information if we need to with comprehensive neuropsychological evaluation. So what do I mean by cognitive impairment? I've sort of been throwing around this term. Well, just to start off with, just to let everybody know that as we all get older, unfortunately, there are certain aspects of cognition that do decline with normal, healthy aging. One of the most common is actually word finding difficulties. That is ubiquitous amongst everybody who is getting older. So as we get a little bit older, our word finding gets a little bit worse. We have to pause a little bit longer to figure out what it is we want to say. But there's a certain level of cognitive decline that is above and beyond what would be expected for normal aging. And the way we know what would be expected for normal aging is decades and decades of cognitive neuroscience research where healthy older individuals in their 60s, 70s, 80s, and 90s have been tested, and we sort of know what we expect as far as normal aging related memory changes. And if your cognition, memory, executive, or visual spatial reduces more than what's expected for age, then that's considered mild cognitive decline. So above and beyond what's considered normal for aging. That's where that comprehensive neuropsychological testing helps, because we have age-associated normative values. What would you expect somebody who's 85 to be able to remember on a word list test? What would you expect a 90-year-old to be able to do on an executive function test who doesn't have any other neurological problems? So that's mild cognitive impairment. What's critical is that if you do have mild cognitive impairment, if there's more impairment on one of those domains than what would be expected for age, it's not to the degree that would actually impair your ability to carry out day-to-day activities. So for instance, you might have a little bit more trouble organizing, but as long as you write everything down, you can still get to the grocery store, you can get everything you need for a meal, you can follow a recipe, and you can get the meal on the table. So maybe it takes a little more effort, but you can carry out that executive function to get the meal on the table just fine. So it doesn't impair your ability, it just maybe makes it a little bit harder. What's important to know about Parkinson's disease is that these early cognitive changes, this mild cognitive impairment, in some people can actually start at the very beginning of the illness. At the time of diagnosis, we can detect some very mild cognitive dysfunction, and that is usually that dysexecutive function. What patients tell me is that they just find it a little harder to multitask at work than they used to. They feel like, they used to be able to juggle 5 things at the same time. Now, if it's more than 2, they feel overwhelmed. And so that's kind of a mild cognitive executive function that I frequently hear from some patients. Now, some patients don't get this at all. Some patients at the beginning of the diagnosis have no cognitive problems whatsoever, test completely normally on these neuropsychological tests, and that might remain that way for a while. But some people do have that at the beginning. So let's contrast that with the term dementia. So dementia simply means that these cognitive deficits are in more than one of the cognitive domains, and they significantly impair everyday functioning, that a person can no longer follow a recipe in order to put a meal on the table. They can no longer go to the store, even with a list, and get everything that they need. They can no longer balance that checkbook, even if they have a calculator or are using some computer program. They can no longer learn some new activity that is essential for everyday functioning. That level of impairment is when we call it dementia. It's not a test score that determines that. It's really how the cognitive deficits impact their ability to perform those everyday functioning activities. That's when we call it dementia. It's the impact on your day-to-day life that's important. Now, dementia can be caused by the Lewy bodies themselves, by the Lewy body disease, Parkinson's disease itself. We know that from many autopsy series that have been done from patients who, after they passed away, have very generously donated their brains to research, who had dementia before they died. And at their autopsy, the only thing we find wrong in the brain are the effects of Parkinson's disease, those Lewy bodies. And so we know that Lewy bodies by themselves can cause dementia. However, as we all get older, some other things can also be going on in the brain. So it's not always just the Lewy bodies. Particularly in older individuals, those in their 80s and 90s, oftentimes we see more than just the Lewy bodies. We can also see Alzheimer's pathology in the brain. And sometimes we can even see vascular pathology. So the results of small strokes that also can impact cognition. So sometimes it's more than one thing that's causing the dementia. And that risk is higher the older you are. So if you're in your 80s, unfortunately, the risk of having more than one thing causing cognitive problems is higher than, let's say, if you're in your 50s or 60s. As the disease progresses, this risk of dementia increases over time. So it's less likely early on and more likely as more and more years of the Parkinson's disease go on. And the last point I want to make with PD and dementia is that in addition to dementia, we also sometimes have patients who experience behavior problems such as anger, aggression, irritability, mania, impulse control disorders, and personality changes. Sometimes these go along with the onset of dementia. And this is probably as the parts of the brain that control those really complex higher order cognition also control some of these other behavior and personality parts of somebody's personality. So they tend to go together. Okay, so what do we do about all this? I saw a question just pop up. So what do we do about cognition? The first thing to do is to make sure nothing else is making cognition worse. So there are a lot of other things that can, unfortunately, they don't necessarily cause the dementia or cause the mild cognitive impairment in people with Parkinson's disease, but boy, do they make it worse. So just like your doctor will tell you going to the physical therapist is really important for helping your walking and your balance, this is what's really important in helping your cognition, is making sure all of these other things are well taken care of. So the first one is medications. Some medications, including some of the medications that are prescribed for Parkinson's disease, can actually worsen some of the cognitive effects. Now, I'm not going to give you a list of these are definitely the bad medications and these are definitely the okay medications, because it's quite individual for every person, the balance between the medications that help the motor symptoms and might worsen the cognitive symptoms. It's really an individualized thing. If you're worried about this, please bring it up to your doctor and say, hey, I heard some of the Parkinson's medications might have a negative impact on cognition. I'm worried about my cognition. Can we just review the list and make sure that I'm optimized with regards to any cognitive side effects of medications? That's a really good personal conversation to have with your Parkinson's doctor. But it's also other medications. Medications for bladder dysfunction can also sometimes be bad for cognition, and pain medications, especially sedating pain medications or sleeping medications. So again, it's a balance whether you need them. I want to focus here for a second on infection, because infection is a really, really important thing that can make cognition worse. In particular, if cognition gets worse over a rapid period of time, over, let's say, a couple of hours or a day. If somebody was making sense for months and months and months, then all of a sudden over 1 to 2 days, boy, they couldn't do anything for themselves. If it was that kind of rapid onset over hours to days, really think about infection. Urinary tract infections in particular. Whenever I get a phone call that a patient's cognition has just really gone downhill over the past 48 hours, I send patients to the acute care clinic to get a urine check to make sure there isn't a urinary tract infection. So always think infection, particularly when cognition changes rapidly. There are other things to check for, such as thyroid function, make sure that patients are being treated properly for depression, hydration and blood pressure. That's what orthostatic hypotension means, is drops in blood pressure when you stand. And then sleep problems like obstructive sleep apnea. And then finally, making sure you're getting all the right information into your brain by making sure your hearing is checked. And I'm going to add eyes. I've had 1 or 2 patients who, after they got their cataracts removed, some of their visual spatial deficits actually improved a little bit. You got to get the right information into the brain in order for the brain to process what's happening. So hearing and eyes are very, very important. Okay, so what are the medications out there? Well, unfortunately, this is a fairly short slide. We don't have a medication that was specifically formulated for cognitive problems in Parkinson's disease. Nothing's quite been developed for that yet. However, one of the medications that was originally developed for Alzheimer's disease happens to work pretty well in helping a little bit with Parkinson's disease. In fact, it works better for Parkinson's disease than it does for Alzheimer's disease. And that is the medication rivastigmine. The trade name is Exelon. It comes in both a pill form and a patch form, a once-a-day patch or a twice-a-day pill. And the 2004 study did support the use of rivastigmine specifically in people with Parkinson's disease. There are a couple of other medications in this class. This is the class of cholinesterase inhibitors. So basically they increase the chemical acetylcholine in the brain. And so donepezil, which is Aricept, and galantamine, which is Razidine, also fall into that category. There's a different category of medication that's under the category of NMDA receptor. This is memantine. The trade name is Namenda. There have been some mixed results. I use it sometimes, but the data is not as strong to support the use of this medication, but this is a reasonable one to consider. So these are the medications that are currently FDA approved for cognition. So there are also really important non-medication strategies. So one of the reasons why I really support patients trying to get as much information about their cognition and their cognitive decline is because that really helps the patient and families make the adjustments they need. So let's take the example of that multitasking. If somebody's having a really hard time incorporating in new information, and coming up with a new plan, then make sure you give them information in small pieces. So for instance, if plans change, make sure that you tell them early if their routine changes, and that you maybe write it down to reinforce that concept. Another thing is that, let's say on memory testing, if they got formal memory testing, sometimes what we do is we give a word list where we give them, 16 words to remember. It's really hard to do, actually. And then we ask them 20 minutes later, what were those 16 words? And people can't remember any of them. But then if you give them hints, some of those words were vegetables, some of those words were animals. All of a sudden, they're able to remember the words a little bit better. That means that the information's stored in the brain properly. It's just hard to retrieve without hints. So if somebody responds really well to what we call category cues or hints, that means that simple verbal or written reminders might really help with them, with their organizing or with their memory. And that's a really helpful thing for families to know. So writing things down, doing things like hints. Remaining mentally, socially, and physically engaged. I really want to emphasize this one. The best way to keep yourself physically engaged is to keep up your physical effort, is to remain physically engaged. It turns out that also can help with your cognition and memory. So really staying mentally, socially, and physically engaged as much as possible, which I know is incredibly hard to do right now. And then finally, you're not alone in this. And finding another person with Parkinson's disease or a support group to share ideas and talk about this. I think this is a really important one to be open about and to talk about, because you're not alone in this. This is something that I think many, many patients and families struggle with, and that can be incredibly helpful to have a community around you as you're dealing with cognitive impairment in Parkinson's, and for family members too as well. So there are some new medications on the horizon, which is great. One of the things that I've had the privilege of being involved with over the past decade is trying to really talk to pharmaceutical companies about how important this topic is, and that they really need to focus on Parkinson's specific strategies for treating cognitive impairment. And we're slowly getting there. These are examples of 3 clinical trials that are currently being conducted that are focused on cognitive impairment in people with Parkinson's disease. Several of them are focused on a more sophisticated way of interacting with that NMDA receptor. And one of them actually is going after one of the less common dopamine receptors that we actually think might be important for cognition. So these are all some currently recruiting, some of them just finished, and I hope that there will be more and more on the pipeline. And I want to encourage anyone who is really interested in this topic to definitely consider being involved in whether it's an observational clinical trial where we just study cognition in Parkinson's over time, or an interventional clinical trial such as the ones you see on here. The only way we're going to convince pharmaceutical companies to be more proactive is that they understand cognitive impairment in Parkinson's more. And the more data we can get from observational studies, studies like mine and others around the entire country, around the world, bring that data and publish it and bring it to those pharmaceutical companies and get them to actually understand how important this is. For interventional clinical trials, clinicaltrials.gov is a great site. For observational studies, those are usually your local, are more local, and so asking your Parkinson's doctor about any observational studies locally is a great way to do that. Okay, and I will wrap it up there so we can leave the rest of our time for question and answer.
Wow, thank you very, very much, Dr. Poston, for that excellent introduction. I know that this just tickled everyone's thoughts about questions that they have. We have about 200 questions that were submitted before the program, and questions have been coming in very fast and furious as you were speaking. So there's a lot of questions out there that our viewers have. So we are ready for our Q&A. Before we turn to that, we actually have a polling question for our audience, and you will see that on your screen right now. Please take a moment to answer that. That will help us gather some information about who's on the call today. A second polling question is going to pop up on your screen in a little while, so be aware of that. Okay, thank you so much for that. And we are now going to turn to our questions. So the first question that has come up again and again and again You mentioned Lewy bodies as something that's in people with Parkinson's disease's brain, but there's also this sort of separate disease called Lewy body dementia. There's another term, dementia with Lewy bodies. It's all extremely confusing, and lots of people want to know, do I have Parkinson's disease? Do I have Lewy body dementia? What are these terms? Can you try to explain those to me?
Yes, excellent question, Dr. Gilbert. And unfortunately, this is not only confusing to our viewers, this is also confusing to a lot of neurologists, which is, I think, part of the problem. So traditionally, neurological diseases were named and described based on the clinical symptoms. And Parkinson's disease, as many of you know, was first described over 200 years ago based on the motor symptoms of slowness, stiffness, tremor, and gait disorder. Over those 200 years, though, many neurologists also identified that cognition and dementia were a big problem in people with Parkinson's disease. Concurrently with that, the cognitive and behavioral neurologists had identified a disease that was predominantly a dementia disorder. What we found out in the 1900s is that when you looked under the microscope, these two disorders, traditionally Parkinson's disease, and then this other disorder that started off as a dementia disorder, both had under the microscope these Lewy bodies, which are basically they're alpha-synuclein, which is a protein that's clumped together inappropriately. Alpha-synuclein is a normal protein in the brain. We all need it. It's super important. But for some reason, it changes conformation and clumps together, and it causes neurons to not function properly. And these Lewy bodies are what we see under the microscope. So we see that in both Parkinson's disease and Lewy body dementia. The only difference between the two is sort of a which came first question, the chicken or the egg. In this case, which came first, the motor or the cognition? So traditionally, if somebody's changes in their neurological system start off with motor symptoms, slowness, stiffness, tremor, gait and balance problems, and those motor symptoms persist for at least a year before they have substantial memory problems like dementia, we call that Parkinson's disease. On the other hand, if somebody's neurological symptoms start with dementia, or within the first year of their motor symptoms they have dementia, we call that Lewy body dementia. The only difference is which came first, and we arbitrarily pick a 1-year cutoff. If that tremor started 360 days after the dementia, we call it dementia with Lewy bodies. If that tremor, or we call that Parkinson's disease because the tremor was within the first year. If that tremor started 370 days after the dementia, so over a year, we call that dementia with Lewy bodies. It is an arbitrary line in the sand, but it's actually helpful because it helps us to identify people who have the predominance of early cognitive impairments versus the predominance of early motor problems. And you can imagine, as we're doing our clinical trials, it's important to recruit the right people for the right symptom into clinical trials. So it is a helpful term to use on the research side. I think, unfortunately, it just is confusing for patients and families. Does that help to clarify a little bit?
I hope so. Thank you so much for that great answer. There are, I want to actually speak to our audience for 1 second. There are 2 places where you can contribute conversation. One is the Q&A and one is the chat. I would encourage you to put your questions in the Q&A box at the bottom of your screen. That would allow us to analyze the questions at the end and answer questions that are not answered during the program. So please put your questions in the Q&A and not the chat if that is possible. Another question that is coming up many times, Scott, for example, asks this: are there physical or mental activities that allow for the slowing of cognitive impairments? Those are really 2 separate questions. Are there certain things certain mental exercises, cognitive, different exercises you can do to help your brain? And are there physical exercises that you can do to help your cognition as well? Could you answer those 2 points?
Yeah, that is really a great question. Thank you for asking that. So the research studies have not proven beyond a shadow of a doubt that mental activities or physical activities clearly slow the development of cognition. But there is some data to suggest that these are helpful, and I'll address them separately. So the physical activities, it's actually quite interesting. Physical activity has consistently been shown to at least boost cognition in people with Parkinson's disease, in people with Alzheimer's disease, and people with other cognitive disorders. So it can help cognition. Does it really help to slow the deterioration? That's a harder question, but it definitely can help cognition, so physical activity. And in fact, in my colleagues who treat patients with Alzheimer's disease, one of the things that they try to really focus on is getting patients physically engaged to help their cognition in Alzheimer's disease. So it's a big, big area of Alzheimer's research. So we think that's also true in cognition associated with Parkinson's and dementia with Lewy bodies. As far as the mental activities, that data is also a little bit conflicting. So I would say, broadly speaking, staying very cognitively engaged is generally thought to be overall good for boosting cognition. We don't know if it slows the deterioration, but there's no one brain game or brain activity that's necessarily been shown to be better than others. And in fact, for instance, take the very popular game of Sudoku. If you like doing that, you get better at doing that game for sure. But does that really help you to balance your checkbook better? Probably not. And so the problem with a lot of these brain games is that you clearly get better at the brain games, but it doesn't translate particularly well to being able to do other things better. I'd say overall, if you enjoy doing those things, I would definitely encourage you to, but they haven't necessarily been shown to absolutely show slow cognitive decline or translate broadly to all cognitive domains.
Okay, thank you very, very much. Along the same lines, you mentioned some medications that can help treat dementia. Are there any medications that slow down the progression of cognitive issues? And along those same lines, any supplements that may be on the market? There are some supplements that actually advertise that they're good for cognition. What are your thoughts on supplements and specific medications to slow down cognitive decline?
It's a great question. So as of right now, there's no medication that has been proven to slow the progression of cognitive decline. And there's been no medication that has been proven to prevent the development of dementia. That is true both for Parkinson's disease associated cognitive decline as well as Alzheimer's disease. So nothing has been proven to slow the decline. Everything we have, the medications I mentioned, are simply symptomatic, meaning that just like, when you take the dopamine, the tremor suppresses. When the dopamine wears off, the tremor might come back. Same thing, is that the medications help symptomatically, but they don't change the overall trajectory. There also has not been any data to support the supplements actually helping prevent dementia or slow cognitive decline. And in fact, most of these supplements don't get into the brain at all. It's actually quite hard to get medications into the brain. The brain's a very protected space, which is a good thing, but it makes it super hard to actually get medications into the brain. And so that is a major problem. So I would be very leery of any type of supplements that promise preventing dementia or slowing cognitive decline. That is just simply not proven, and unfortunately is probably just not true.
Okay, well, thank you for that. We have a number of people asking. I see Paul, for example, asked the question, what is the relationship between DBS and cognition? Can DBS help, or that's deep brain stimulation? Can it help cognition? Can it hurt cognition?
Really excellent question. So I'll address those separately. So can DBS help cognition? Right now, the targets that we have for deep brain stimulation, the thalamus, the subthalamic nucleus, and the globus pallidus, do not help cognitive impairment. There are some research studies going on looking to see if there are other targets in the brain that might be able to improve cognition, but the three that are FDA approved do not help cognition. So if your goal for surgery is to improve your cognition, that's not a good goal for surgery. Make sure your goals for surgery are very clear with your physician, because it's not going to help your cognition. On the flip side, there are some people who DBS could actually hurt their cognition. And I want to emphasize the some people part. And this is why doing a really thorough and proper pre-DBS evaluation is critical. Because one of the things I know we at Stanford really focus on is identifying the people who might actually be harmed regarding their cognition by having deep brain stimulation surgery. There are only certain people, and those are people who have already shown significant drops on those formal neuropsychological tests prior to surgery. So they've already shown that their cognition has deteriorated substantially enough that the deep brain stimulation surgery will actually make it worse. If somebody performs cognitively within the range of what is expected for their age on all those cognitive tests, the data has not shown that DBS is detrimental for cognition. So we do a very thorough cognitive testing before doing DBS, and I would encourage anybody who's thinking about DBS to make sure that that evaluation is part of the pre-DBS evaluation plan. It's not just seeing if the tremor and the slowness and the stiffness are appropriate for DBS, it's also making sure that that it's not going to make something worse like cognition. And that's all part of the pre-DBS evaluation.
Thank you very much. We have a number of questions. Catherine is one of them who's asking, can you address young onset Parkinson's disease and cognition specifically? Are there differences to consider if your Parkinson's is diagnosed at a young age?
It's a really fabulous question. I briefly mentioned something about how long you've had Parkinson's is one of the influencers on cognition. But what I didn't mention is that there's an interplay between age and disease duration. So for instance, people who are older at the time of their Parkinson's diagnosis, so 70s and 80s, the duration of time it sometimes can take to have cognitive problems can be a lot shorter. Whereas people who are much younger when they are diagnosed with Parkinson's disease in their 40s and 50s, oftentimes it can take much, much longer for them to have any cognitive problems. Sometimes those younger people can identify some early dysexecutive function, some mild dysexecutive function, and that's a good thing to be aware of, particularly as it pertains to how you organize your job and other things that I think are more problematic for younger individuals with Parkinson's disease. But severe cognitive problems oftentimes don't develop for many decades. Now, giving these two big buckets, I have to say there are exceptions to those rules. I have the top of my head can think of an 85-year-old patient who's had Parkinson's disease for 15 years and his cognition's doing great. And unfortunately, I can also think of a 55-year-old patient who's had Parkinson's disease for 15 years who's struggling with their cognition. So there are exceptions to these age and duration rules. And that's what a lot of the research is trying to figure out, is more a personalized approach of figuring out who's at risk when. But right now, what I would say for those of you who are younger, oftentimes we think of younger onset Parkinson's disease as a more motor predominant disorder. That's not always true, but that is frequently the case.
Okay, thank you so much. Along the lines of trying to find ways to slow down the cognition, we discussed medication, supplements, we discussed exercise and mental exercise. What about diet? Are there any specific diets to consider? And someone specifically asked about the Mediterranean diet, if you could address that.
Yes, absolutely. So broadly speaking, in Parkinson's disease, there's no specific diet that has been identified to really be the diet that is the most beneficial for everybody with Parkinson's disease. However, I did mention that one of the things that we sometimes see at autopsy in patients who have dementia with Parkinson's disease is that they can also have vascular abnormalities or small strokes. And what we have found is that people who have Parkinson's disease who also have small strokes or larger strokes as they get older, their cognition, unfortunately, is very specifically affected by that combination of strokes and Parkinson's disease. So what I would recommend is any diet that your heart doctor tells you is the most appropriate for preventing heart disease and stroke is probably the best one for you. And so anything that helps to prevent your stroke risk, which is usually similar to preventing your heart attack risk, is probably the best. Not that it helps the Parkinson's specifically, but it helps prevent a double hit. And so with regard to the Mediterranean diet, there is some data to suggest that the Mediterranean diet can be helpful in reducing heart attack and stroke. I will say this has not specifically been studied in people with Parkinson's disease who are at risk for also having stroke. So there's not a lot of data to support that, but this is sort of a, A equals B and B equals C. So I'm hoping that A equals C kind of situation. So, so protecting your brain against strokes is a good thing.
Okay, fantastic. So just to summarize a little bit of our conversation so far, people out there, we have close to 800 people joining us now. Everyone is invested in understanding their cognition in their PD. And what I'm hearing from you is really aren't any medications that slow down the disease. Supplements are not necessarily the way to go either. Maybe there's some help with diet, maybe some help with exercise, plus minus mental exercise. What do you tell your patients who need guidance? They're having cognitive issues. It's affecting their life. They want to maximize their quality of life as much as possible. Are there tips to improve functioning? Are there strategies that help people really maximize their quality of life when they're faced with these challenges?
It's a really, really important question, and quite frankly, a difficult one considering we don't quite have the medications, but that doesn't mean we don't have anything. So Dr. Gilbert mentioned that I have an engineering background, and so I approach these things from a very engineering perspective. And so the first thing I tell patients is understand the problem. Understand the problem that you're having. That to me is always my starting point, is that I need to understand what the problem is that's in front of me. And so getting sometimes that more sophisticated neuropsychological testing can be a really good starting ground for understanding what the problem is that you're having. Because I mentioned, this is this executive function and this visual spatial problems and sometimes memory, but not everybody has the same combination of those things. Some people, it's more of a visual spatial problem. Other people, it's more of an executive problem. Some people, it is more of a memory problem, just a straight up memory problem. Understanding what the problem is for you as an individual is really the first step, because then things can be altered or changed in your environment, in your day-to-day living to accommodate. In the same way that when you think about, well, gosh, when I first wake up in the morning, I have a lot more bradykinesia because my first dose of dopamine hasn't kicked in yet. That's the problem, is that the first dose hasn't kicked in yet. There's more bradykinesia. So how do I solve that? I give myself more time to get ready in the morning after the first dose of medication. So again, that's sort of the approach. Similar to cognition, understanding what the problem is this mostly an executive problem, a visual spatial problem, a memory problem, is often a first step. And so asking your doctor about that and whether additional testing is helpful, I think and then having that doctor explain that testing and what it shows and how that might help you to make some adjustments and changes in your day-to-day life. I think that's really one of the most beneficial things that I don't often see happening for patients, is getting that information. It's just as important as understanding how the tremor and the slowness change as the day goes on, understanding how the cognitive functions are affecting your life.
Fantastic. So as a corollary to that, there are a number of patients who've asked, or people on this Zoom who've asked, should I be getting cognitive testing as a baseline when I don't necessarily have issues or my issues are very mild? Do you routinely order cognitive testing in that situation?
I don't think it's a bad idea to do cognitive testing just to sort of see where things are. As I mentioned, we use age appropriate normative values to determine whether somebody is below what would be expected for age, but not all 65-year-olds have the exact same executive ability, and we all have our strengths and our weaknesses. And so having your own baseline is actually a pretty reasonable thing to consider, because then if there is a change over time, it's something that's a little more personal to you to consider. And so while I don't broadly order formal neuropsychological testing on every single one of my patients, and some people are a little reluctant, they kind of would prefer to not know. I definitely understand that desire, but if you're somebody who more information is helpful for you, I would absolutely consider it. I think it can be of value to you as the patient and the family, just to have a baseline to work off of.
Okay, fantastic. There are a number of questions that came in during registration relating to COVID, as well as the COVID vaccine. So people were curious, does COVID affect cognition, specifically in people with Parkinson's disease? And if I already have some cognitive problems, has there been any reports that the COVID vaccine may make that worse? So if you could address that, it'd be great.
Yeah, absolutely. And this is an area where the data is continuing to come in. There are many, many wonderful Parkinson's researchers around the world who are really gathering as much data as they possibly can on their patients to understand the impact of COVID. What it appears right now is that COVID affects Parkinson's disease kind of the same way any really bad infection affects Parkinson's disease. So I don't know if you all remember a couple of years ago, that really terrible flu season. I think it was 2017. It's one of the bad flu seasons, at least here in California. And a lot of patients had the flu. And boy, did it wreak havoc temporarily on their Parkinson's disease. Their tremor got worse when they had the flu. They were slower, their balance was worse. And for many of them, their cognition was worse during that. But after the flu, slowly, that was one that lingered for a while, slowly went away and people recovered, those symptoms of Parkinson's all improved. Again, whenever you have Parkinson's disease, if you have any kind of infection, it will temporarily make everything about your Parkinson's worse, including cognition, just as it does tremor. And that's basically what we're seeing with COVID, is that patients who are infected, everything gets worse. The tremor gets worse, the balance gets worse, and the cognition gets worse. But we're also seeing recovery in patients who have fully recovered from COVID. They're going back to their baseline. And so we don't think this is a permanent impact. And in fact, most of the studies don't indicate that there is much infection directly to the brain at all. Again, the brain's a protected space, which sometimes works for us in the case of infection. So that's disease. Again, more data is always coming. We still need to understand the long-term effects, but that's what we understand. Regarding vaccination, the data so far from the very large studies, the published studies were over 40,000 patients per study, the first two, the Moderna and the Pfizer vaccine, appears that in all older individuals across different types of neurological and other general age-related diseases, that there was no negative impact on those diseases. And I know here in California, we've been able to start vaccinating our patients, and I am not seeing any negative effects of the vaccine in my patients who have already gotten vaccinated. I will just say, broadly speaking, the second dose is a bit of a whammy. I've already gotten my second dose, and boy, that knocked me out for about 2 days. I just felt fatigued and achy. I felt pretty lousy. So I would definitely expect for the second dose, for those of you getting vaccinated, the tremor might get a little worse. You're going to feel a little fatigued. That could definitely happen, but it goes away after a couple of days. And so other than the general effect that we're all going to feel after the second dose, it was balanced by the overall happiness that I had of getting vaccinated. So I was willing to put up with 48 hours of fatigue and achiness, and Tylenol helped.
Mine wasn't so bad. My second Moderna shot wasn't so bad. Just a little soreness in the arm, and all was good.
Maybe I'm just a wimp, so.
There's variability, as we all know. I have an important question from a person that I want to address now, which is, her feeling about this presentation is that everything is very depressing about what you've said and negative, and Can you say something encouraging? Are there any encouraging signs, any research, any future developments that we can point to give hope to our listeners about cognition and Parkinson's disease?
Yeah, I definitely feel that pain of that. Unfortunately, I don't have a lot of groundbreaking, encouraging positive news. But I will tell you what is really encouraging and positive is that there is a very large focus right now, both within the Parkinson's community, in the biotech industry, in funding sources like the NIH, and other foundation sources like the APDA, that really understand that this is a major, major unmet need in the field of Parkinson's disease. It constantly comes up that we need to address this. Again, it's been an ongoing conversation for the last 10 years. And I've seen, pharmaceutical companies actively, get engaged in this area where 20 years ago they weren't. And so I think that the awareness campaigns that people with Parkinson's have really put forth in trying to raise awareness have made a difference, and the funding agencies are listening, and the pharmaceutical industry is listening. And so the fact that we have 3 cognitively focused clinical trials going on right now is a huge win compared to where we were 20 years ago. And so I am very encouraged that the way that I am treating cognition and Parkinson's disease today will be very different than the way that I will be treating cognition and Parkinson's disease, hopefully 5 years from now. But I really think, in the next decade, we're going to see some game changing influences. So I'm very encouraged for the future. I wish it could be here tomorrow. And I'm doing everything I can to try to make that happen.
So I just want to emphasize that this entire recording, including the slides, are going to be available on our website within the week, and you will be able to reference the entire presentation, and in addition, that slide where it listed the clinical trial. So a lot of people have been asking, well, how do I find out more information about the clinical trials? That slide with the 3 trials had what is called NCT number. And you just Google that NCT number, put that into your web browser, and it will pop up a website which describes the trial and where it is and how you can join if you are eligible. So look out for that, and we'll send you that information, whoever is on the Zoom today. A lot of people have been asking about hallucinations. We've not mentioned this at all yet, so we really do need to talk about that before our hour ends. Can you talk a little bit about hallucinations, their relationship to cognition, how they may be treated, sort of the interaction between those two things?
Absolutely. Several studies have shown that the development of hallucinations and the development of dementia in the context of Lewy body diseases, whether that's dementia with Lewy bodies or Parkinson's disease, tend to happen around the same time. Now, they're not definitely time locked. There are definitely people who have hallucinations who don't have dementia, and people who have dementia who don't have hallucinations, but they tend to be associated with each other. And that's probably because they're probably coming from similar areas of the brain that aren't functioning quite properly. So let me just give you the spectrum of hallucinations. The very, very mild ones are things that we call illusory phenomenon or illusions. We all get these. You see something in the corner of your eye and you think there's maybe a dog running by, and you kind of turn your head and you realize, oh, that's just a purse on the ground. Or you see something move outside the window, you think somebody's there, and you realize it's just, the bushes rattling. That's intensified in people with early hallucinations, where they're kind of seeing these illusory phenomena all over the place. And sometimes they actually see that dog or see that person when they look at it. When that starts to happen, where they actually see a fully formed figure, that is considered a visual hallucination. It can also come in the form of what we call a sense of presence, where you just feel like somebody's there, even if you don't fully see them. You just feel like someone else is in the room or someone else is in the house. Those are kind of those early hallucinations. Oftentimes, patients have full awareness of those hallucinations. They know that dog is not there. They know that person is not outside the window. They see them. They're absolutely visually there for them, but they totally know that they are not real. When those become more difficult to decipher what's real or not real, and patients don't have that insight into whether or not the hallucinations are real, that's when they become more severe, and the hallucinations can actually become delusions, where patients think that that person outside the window is maybe trying to break in, and an entire story around a delusion starts to occur. And those are the very severe ones. So hallucinations, the spectrum of hallucinations, oftentimes dovetails the onset of dementia. So we treat them very similarly together. Again, some of those Parkinsonian medications that help with tremor and slowness, unfortunately, can worsen the hallucinations. So the first thing to do is to review the medication list and make sure there isn't anything medication-wise that's really enhancing the hallucinations or making them worse than they really can be. There is also a medication that is FDA approved for hallucinations, pimavanserin, that has some data to support that it can be helpful in some people.
Excellent. So a similar question around the symptom of apathy. Perhaps you could discuss a little bit about what apathy means and how does it relate to cognition, and how can it be treated or addressed?
Yeah, so apathy is, again, another one of those symptoms that very frequently tracks with cognitive impairment and dementia. So people who have apathy, or as apathy is worsening, that oftentimes is around the same time that cognition is worsening. Not always, but it can be an early sign. So apathy it's different than depression. It's not depression. It's apathy is lack of interest or engagement in things that a person used to be interested in or engaged in. So someone who was an avid exerciser their whole life, just now, there's just no interest. There's no motivation. There's no interest. There's no engagement. They just completely kind of cut themselves off from that. And so that's what we ask about with apathy. So it's not depressed mood or feeling low or sad. It's just complete loss of interest. And that oftentimes again, can happen early on or at the same time as cognitive impairment and dementia is occurring. Treating apathy is quite difficult in any patients, in Parkinson's disease patients. Sometimes some antidepressant medications, though, can help a little bit. And so talking to your doctor about specific medications that, again, traditionally do address depression, but sometimes can also be helpful specifically for apathy can be helpful for that symptom. And oftentimes when patients increase their interest and increase their engagement, their cognitive performance can improve as well. So sometimes cognitive impairment is sometimes mistaken for apathy. So making sure that you distinguish between those two, because you would treat it very differently.
Okay, fantastic. We are really nearing the end to our hour, and so we really have time for one last question. And I'll choose one that more than one person has brought to our attention, and that is the role of music. Many people have suggested that music can be very helpful for Parkinson's in general, for cognition, potentially learning a new instrument or getting involved in music. What are your thoughts on music to help with cognition?
That's a lovely question. And I'd say music and art in general is actually a wonderful way to engage the brain in ways that that help to improve movement. So music in particular, because it has that rhythmicity to it and that external rhythmicity. We all know dance for Parkinson's is a huge thing and is just an incredibly helpful thing. It also, by the way, is very helpful for mood. I mean, music, it has a way of touching us emotionally that really not a lot of other things do. And so that mood and apathy, I think music is a great way to engage, but then also cognition and dementia. And I think music is we don't have a lot of data around this, but I can definitely say anecdotally from my patients' experience that music is a great way to just engage people. And I would extend that beyond music to other art forms as well. I know that painting and drawing also can, for certain people who are so inclined and have those interests, can also be extremely helpful for mood, for apathy, and for cognition. So I would absolutely encourage that in everybody.
Fantastic. Thank you so much. So that hour went by extremely quickly. As I mentioned, we had close to 200 questions before this program started and over 100 that came in during the program. I would like to tell everyone who is now listening, I am going to try my very best to answer everyone's question. Give me time. It's going to take me a while, but check your email and hopefully you will get an answer to what you asked if Dr. Poston did not answer it in this hour. So be aware of that. And I want to thank Dr. Poston so much for all that wonderful information, the presentation, for the Q&A session, and to everyone who participated in today's discussion and submitted questions. If you missed today's program or missed part of it, if you joined late, if you want to watch it again, send it to somebody, etc. As I mentioned, it will be on our website, apdaparkinson.org. It will also be on our YouTube channel. So please feel free to share it, watch it again, etc. For more information, for resources, again, our website, apdaparkinson.org. I want to mention 2 upcoming programs that you may be interested in joining us for next week, Wednesday, February 24th at noon. We will be presenting a virtual research roundtable where 4 of our APDA funded researchers would tell you about their work and answer your questions about Parkinson's disease research. So that's going to be very interesting. And then the next episode of Dr. Gilbert Hosts will be Wednesday, March 17th at noon. And I will be hosting Dr. Clemens Scherzer, who will be talking about genetics and Parkinson's disease. If you're interested in these presentations or other of our resources or programs, you can register for these in our virtual calendar. The way you find that is go to, again, apdaparkinson.org, and we have a tab for virtual calendar in the upper right corner. And you scroll down to February 24th for our research roundtable and March 17th for our next Dr. Gilbert Hosts. So we hope we're going to see you on those presentations. If you enjoyed today's webinar, we hope you will consider supporting APDA with a donation, because with your help, we can deliver more programs and services like this one, which are needed, obviously, more now than ever. And finally, I want you to remember to check out our APDA symptom tracker, which is an app that helps you or your loved one track their PD symptoms. The symptom tracker is available in English and now in Spanish and can be downloaded from the App Store or Google Play. So once again, thank you so much, Dr. Poston. Thank you everyone for joining us today. And we hope to see you very soon on another APDA program. Have a wonderful afternoon.